It used to be that consumers were in the chorus line with the employers in the plan front and center making decisions about health insurance. Now they've been pushed to center stage because of a lot of changing things in the marketplace, among them being high deductible health plans, changing reimbursement models that really require them to pay much more out of pocket. The economic climate is challenging, and there are narrow and tiered networks emerging that are really requiring them to roll up their sleeves to understand how that impacts them. Now the challenge is on crafting and designing tools that are meaningful, user-friendly, and effective. We are now moving much more into episodes of care and bundle payments, and to start creating chronic disease profiles. So if you have type 2 diabetes, for example, you can look over the course of a year what would be recommended to maintain or to really be a best advocate for your condition, and understand what the costs associated with that care could be, and to help with plan selection and plan management.
Shared decision-making is a term that arose out of the 1982 President's Commission on the Ethical and Legal Implications of Informed Consent. We find that patients' choices are much more aligned with their values and preferences. We find greater knowledge gain, less decisional conflict, and studies show that when we do this, patients often will decline surgical procedures somewhere around 15 to 20%. The challenge will be taking it large scale, making sure that shared decision-making is defined adequately, measured, and that any kind of payment for shared decision-making is tied to measuring that it's actually happening and tying it into quality metrics.
We're doing a lot of effort in trying to engage with the providers because we see this partnership historically being, us and them. We really believe that the future of the healthcare ecosystem, how we're going to be successful, is working together. And that talks about how we collaborate not just on pricing, but collaborate on quality of services, on reporting and analytics, and really data sharing that allows them to get access to a lot of data about that patient that they couldn't access inside of their single EMR system. There is a lot of transactions and services being provided in the providers' offices that data is trapped inside of their EMR systems. And so what we're doing is trying to connect directly to large provider systems through their EMRs and interchange that data to enrich the administrative data with that other clinical data, as well as connecting to health information exchanges that are mature in certain states like Indiana and California and Georgia.